Thanks the Cox team for giving me this opportunity. Let us go to the topic, birthing questions and tools. No, it's even though it's a traditional, cultural oriented topic, we'll see what is happening in the field and today's obstetrics. So when you want to the ketchup to come out of the bottle, you don't lay the bottle down. It's the same when you want the baby to come out of the mother. So let's see what's happening with the mothers in the laboring room. So before going into the topic, we have to take into account the guiding principles for the WHO intrapartum care model. So it should be individualized and women-centered, the labor should be, and there's no intervention should be implemented without a clear medical indication, and the only interventions that serve an immediate purpose and proven to be beneficial for the mother should be promoted, and a clear objective that a positive childbirth experience should be taken by the mother in the laboring room. So with these principles, we have to approach the mother for the birthing questions. So introduction. So the second stage of labor, it's a very stressful period for the mother, and it will be 50 minutes for nullipara and about 20 minutes for multipara, but which is absolutely highly variable in mothers. The second stage of labor is often most stressful part of the childbirth process for the women and the fetus, and consequently for the care providers for us too. So adopting an unfavorable position, the women might suffer from a series of negative outcomes such as severe perineal trauma, postpartum urinary incontinence and greater blood loss. So how can we prevent? By promoting a good birthing positions which suits for the mother. We have to choose with the help with the mother. So till the mid 17th century, a French obstetrician Françoise Marie introduced semi-recommend question to women during the labor for the easy access in applying forceps. Then this question is popularized to many developed and developing countries around the world and gradually evolved into a recommend or lithotomy question or horizontal questions. But WHO recommended upright question in 1996 and stated women should choose the maternal questions according to their choices and preferences. So since no evidence exists to support the most ideal maternal questions for every woman, the maternal question has been controversial for a long period of time. So what are the barriers to alternative questions from changing from one question to other question? So reason, historical precedent, pervasive cultural image of birth, ease of interventions, healthcare provider comfort and convenience and their training, and physical structures of labor or delivery room. That is example, in overcrowded and lack of space, we cannot adopt certain questions. So what are the common maternal questions we know during the second stage of labor? So maternal questions can be classified as upright or vertical questions, horizontal questions. These vertical questions could be sitting, squatting, kneeling, and horizontal question could be lateral, supine or lithotomy questions. So sitting question is on the bed, chair or stool with one trunk tilted to more than 45 degrees to the horizontal, and it is most popular in Western developed countries than in our Asian countries. In a French study, it's the most common maternal question during the second stage of labor, approximately 30%. So squatting question, lowering the trunk from the standing with certain supports to the keep the balance, but it will be very difficult for the pregnant patient to maintain squatting for a long time, especially in the second stage of labor. So very few women assume this question during the second stage. So kneeling question with one trunk upright or palms on the ground or cushion. In some developed countries, this question is one of the most frequently used questions, and midwives are well trained to support the women in this question. So compared with the other questions, kneeling questions are rarely used in some Asian countries. So lateral questions, also called side-lying questions, including pure side-lying or the exaggerated Sims position, semi-prone, but easily reproducible and comfortable for the patient. The supine question, lying flat on one's back or elevating one's trunk to less than 45 degrees to the horizontal, But several evidence-based guidelines encourage and help women to move and adopt any position they find most comfortable throughout labor and childbirth except supine or semi-supine position, maybe because of this iotocaval compression. But despite the scientific evidence against the use of supine position, the supine positions are the most common position assumed by the women during childbirth worldwide. So lithotomy position, lying flat on one's back with legs raised. Despite the fact that lithotomy position offers convenience for the midwives and obstetricians to monitor the progression of labor and implement certain maneuvers when necessary, the concerns persist regarding the risks of such position. As I said, it's because of iotocaval compression and the fetal distress in when the labor it's not progressing well. So how will we compare the positions with respect to labor progress, the outcome? The labor progress, maternal pain, perineal trauma, blood loss and fetal well-being. So we will take all these points together and we can come to a conclusion. So in coming to accelerating the progress of labor, most recent Cochrane review which explored the impacts of positions during the second stage of labor on women without epidural suggested that upright positions can reduce the duration of second stage of labor by mean of 6.6 minutes compared with supine position. So it's due to gravity effects, contractions are stronger and more effective in upright positions and increase the size of pelvic diameter, thereby enabling faster labor progress. And horizontal positions are less likely to accelerate the labor progress. It requires women to push against the gravity and puts the fetus in an unfavorable drive angle in relation to pelvis. And even the contractions are frequent but less effective in supine or lithotomy position. Alleviating the maternal pain. So, active phase of second stage of labor, pain severity was significantly less in squatting position and the patients were more satisfied in the squatting position. And sitting position also, Indian study indicated that a semi-sitting position was correlated with less labor pain because it avoids the pressure from the weight of the uterus on the waist, which may relieve the back pain, and greater sense of control and better self-efficacy, which may reduce the women's pain perception, thereby relieving the labor pain and it shorten the labor. The supine positions and lithotomy are devoid of the favorable psychological and physical mechanism to reduce the labor pain, and there will be more direct pressure from the fetal head on the vaginal wall in supine position, and this can increase the pain. So reducing the perineal trauma, lithotomy positions and supine positions are regarded as risk factors for severe perineal trauma when compared to the upright positions and lateral positions. Like lithotomy positions can increase the risk by 7.1%, in multis 2.6%, and there is more stress and tension on the perineum in these positions, and there is a greater pressure on the anal sphincter. So compared to decreasing blood loss, the possible greater blood loss in upright positions, and a recent Cochrane's review based on women without epidural anesthesia, it reported that upright positions were associated with an increased estimated blood loss more than 500 ml when compared with supine positions. But there is no clear difference in the blood loss between upright and supine positions when the low quality trials were excluded from the analysis. So promoting fetal and newborn well-being, the upright positions and lateral positions in terms of fetal heart rate patterns are evidenced by the theoretical mechanism that avoids the compression of intra-abdominal vessels, especially the IVC. Thereby, fewer fetal heart rate patterns are found in these positions. So when women assume lithotomy or supine positions during labor, the intra-abdominal vessels may be compressed. So accordingly, it will lead to inadequate maternal blood flow into the placental and causing uteroplacental coefficient decline. So more fetal heart rate abnormalities can be noted. So other asymmetrical positions that we might follow. So stair climbing. It opens the pelvis, allowing the baby to drop further and push on the cervix, and helps the baby rotate and get into the better birthing positions. But it could be tiring, especially when the labor is very much prolonged. And lunges. So kneeling lunges or standing lunges. It helps the baby rotate or descend, opens the pelvis, giving baby more room. But it requires a partner to help you keep your balance. So pushing and birth with the help of a bars. So it expands the pelvis, uses gravity to push the baby down, but the bar cannot be available in all hospitals. So water birth, warm water can be very soothing and contractions are less painful. Our patient will feel the pain very less, and it can be monitored. Labor can be monitored in the pool also, and patient can move around very easily in the water pool. So maternal and neonatal outcomes of we can see in a single slide. Maternal and neonatal outcomes of different maternal positions during the second stage of labor. Lithotomy positions, obstetric and anal sphincter injury, and abnormal fetal heart rate, and supine positions, urinary incontinence, abnormal fetal heart rate, obstetric anal sphincter injury, and in the sitting positions, less labor pain, increased blood loss, and shorten the second stage of labor, but oasis and fewer episiotomies. Kneeling positions, fewer episiotomies, shorten second stage of labor, and fewer perineal tears. Maternal and neonatal outcomes of different maternal positions during the second stage of labor. In the squatting position, fewer tears and shorten the second stage of labor, less labor pain. Lateral positions, fewer tears. So promotion of birthing practices that recognize women's rights. So respect for the beliefs, traditions and culture. The right to information and privacy, the right to have liberty of movement during labor, the right to choose and have a companion, the right to choose the position for childbirth. So always before choosing the position for the patient, always talk to the patient whichever she feels comfortable and it's easy for her to adopt, we can choose. And of course it should be a safe for baby also. So to conclude, be accountable for giving good care as an obstetrician, and it should be evidence based and beneficial. Communicate well with the patient and support her choices, and explore the opportunities for collaborative working and team building to improve the respectful quality of care. So whatever we discuss and learn and implement, ultimately the laboring mother will teach a new technique in the labor room at the end of labor. Thank you.